Good afternoon. Okay, can everyone hear me?
Yes.
Okay. Good afternoon. My name is Joseph Wright. I am the President and CEO of University of Maryland Prince George's Hospital Center, and also the Chief Medical Officer for University of Maryland Capital Region Health. It gives me great pleasure to welcome you to our Grand Rounds presentation this afternoon. We are very privileged to have an outstanding speaker. I have had the honor of hearing him present in several venues, and I want to acknowledge Regina Boatway for securing Dr. Lupu to present Grand Rounds this afternoon. I will introduce Dr. Lupu and we can get started. Dr. Yele Lupu is Ernst & Young, America's Chief Medical Officer, and is a proven physician and business leader, MD, MBA, a physician executive and corporate leader with more than 25 years of clinical and administrative leadership experience within the U.S. healthcare system. He has provided and demonstrated the ability to implement tactical execution and enabling processes that hold healthcare providers accountable for delivery of consumer value in the industry. Dr. Lupu is a leader within Ernst & Young's physician enterprise, operations, and clinical integration practice. His client engagements have included providing assistance in the integrated performance optimization, cost containment, and revenue growth strategies for the hospital and physician enterprise, clinical operations optimization, technology-aligned operational transformation, and value-driven care. This is something that's very important to us here in the state of Maryland, where we are a highly regulated state who is trying to adopt the value-driven care approach. He is a former senior vice president and medical director at a Southeast Integrated Healthcare System. His responsibilities there included governance of an enterprise-wide clinical strategy overseeing program growth, clinical integration, physician alignment, and accountability to develop service lines, vision standardized, and clinical operational and business processes related to the physician enterprise. He is certified by the American and Canadian Boards of Internal Medicine and the American Boards of Cardiology and Interventional Cardiology. He is a fellow of the American College of Cardiology and the Society of Cardiovascular Angiography and Interventions. Clearly, Dr. Lupu has a lot to offer, and I will get out of the way. And without further ado, thank you for being here.
Good afternoon. Can you hear me? Is that a no? No. All right. That's better? Yes. Good afternoon again. My name is Yele Lupu, and I want to sincerely thank you and appreciate the invitation from your graduate medical education leadership to ask me to come and share thoughts with you today about a topic that is very near and dear to me and should be to all of you working as physicians and healthcare providers in the audience, on a burning topic that has and continues to receive less than the required attention from the industry. We're going to talk today about physician burnout. And we're going to talk about it in the perspective as it being described as an ignored public health crisis. And by so doing, we shall attempt to understand the impact and implications of physician burnout, both from a personal perspective, from a societal perspective, as well as from an industry perspective. So what you see on this slide, you probably can't see it, is the agenda to guide the conversation today. We're going to cover a number of pertinent agenda topics, starting with the role and the value of the physician and the physician enterprise within the industry. We shall then attempt to codify a definition of physician burnout. And beyond that, we're going to look at the prevalence of physician burnout within the US healthcare industry and examine the fundamental causes for physician burnout. And we'll also look at the relevance of the cultural norms that exist, starting from medical school and permeate through residency training and a physician's career that contribute causes to the onset of physician burnout. We'll also look at the complex industry megatrends that exacerbate physician burnout, and by so doing, understanding the causes, we're able to look at the consequences of burnout, again from the perspective of the individual, the organization, and society at large. Finally, we'll attempt to shed light on evidence-based solutions that may be used to avert physician burnout, doing this through health system investments into physician resiliency programs, and identifying the importance of health system organizational culture contributing to physician burnout. More importantly, we shall shed light on new and evolving models of medical education and physician postgraduate training, new models that are geared to reimagine the provider workforce of the future. So, what is the role and what is the value of the physician? I think this is a very important place to start. Now, obviously, the role of the physician is to provide diagnostic accuracy and effective treatment to patients. This done humanely and with empathy. Now, fundamentally, this is done in order to alleviate pain and suffering of our patients, in order to prolong life when appropriate, but also to respect the dignity of death when life prolongation is devoid of quality of life, and when prolongation of life is associated with untold burdens to the patient, to the patient's caregivers, and indeed to society. So very simply put, physicians seek to make their patients live longer and to live better. What is less often verbalized is the role of the physician as being obligated to be a responsible custodian of the resources within the industry and to have a commitment to deliver and to be held accountable for the delivery of excellent care at the best cost of care. So what I've said now pretty much contextualizes the role of the physician. Let's speak a little bit about the value of the physician and of the physician enterprise. It is probably somewhat paradoxical to ask what the value of a physician is in the industry. After all, I doubt that anybody in this auditorium today, indeed I doubt if anybody on the planet will suggest that the physician does not have immense value. That is indisputable. The more germane question, though, is whether this value is appreciated. And if so, how is this appreciation measured and rewarded beyond financial remuneration? So I'll offer that the value of the physician encompasses a long spectrum of data points, ranging from the humanistic ability to promote individual and societal health. And if one is successful at doing this, by so doing, it provides immeasurable value that can't be quantified in dollar terms. by providing workforce stabilization, economic stability, enhanced quality of life, and longevity. Now, from an economic perspective, it's important that we all understand and appreciate the following facts. The economic engine of the healthcare industry is driven by physicians. Physicians work within a very complex human ecosystem and infrastructure that involves multiple team members and players. But the physician has the unique position of being the entity that generates revenue by way of actions that they do by way of the power of the pen. Hardly any reimbursement in most healthcare systems occurs. Hardly any revenue is generated, for the most part, without a physician order behind an activity. Be it hospital admission, be it a referral for a specialist, be it a referral for a diagnostic test. Not to overstate the importance of physicians, but if we look at this from an economic perspective, we must understand and appreciate that the financial engine is driven by physician behavior. And finally, and fundamentally, physician value is indispensable in actualizing population health. Population health as defined by the broad societal metrics of infant mortality, life expectancy, per capita spend on healthcare, and cost-efficient value-driven healthcare. So, having gotten a grounding on the role of the physician and the value of the physician, the context of physician burnout that erodes the competencies and efficiencies of a human capital portfolio of significant importance. How do we define physician burnout? So this slide states that physician burnout is defined as long-term stress reactions characterized by a constellation of symptoms such as emotional exhaustion, the onset of depression, or behavior traits such as depersonalization in clinical interactions, negativity towards patients, the very population that we have committed to serve, a decreased sense of personal achievement, lack of empathy, and dysfunctional interpersonal relationships, not just at work, but also at home. These symptoms and more, when seen in isolation or even in combination, these are all red flags for actual or indeed imminent physician burnout. What is the prevalence of physician burnout in the United States? If you look at this slide, it sheds some light onto how significant a problem this really is. Well, almost 45% of physicians in the United States, based on surveys over the past 5 to 10 years, reveal that almost up to 45% of physicians report symptoms, multiple symptoms of burnout. And in some surveys, as recently as 2 years ago, as many as 54% of physicians have reported 1 or 2 symptoms of burnout. And sadly, one of the consequences of burnout is suicide. And up to 400 physicians in the United States commit suicide a year. And this number is higher than in any other industry in the United States. Furthermore, If you look at it through a gender lens, burnout is 11% more prevalent in female physicians than in their male counterparts. You may ask why, and I would prefer a suggestion that this is probably a manifestation of the unique gender-related work stress, gender-related work inequities, discrimination and harassment that is experienced by women in the medical profession, perpetrated and ignored by a male-dominated health industry leadership. So we're talking about physician burnout, but I want to mention a word about the nurse provider. You know, nurses routinely work shoulder to shoulder and knee deep at the front lines and in the trenches with physician partners, dispensing bedside care with physicians. Indeed, it is a well-established fact that the nurse provider spends more time with patients than the physician provider, caring at the bedside. So what do we know about nurse work-life balance or imbalance? So sadly, as you see from this slide, similar statistics are evident in the nursing profession. More than 40% of nurses report symptoms of disengagement, and more than 15% of nurses report symptoms of burnout in the high-intensity specialties of emergency medicine and intensive care medicine. 1 billion nurses are projected to retire by 2030, at a time when the demand for nurses will increase by 15% through 2026. Nurses who are unengaged are professionals who have diminished morale and who have difficulty integrating into teams with their colleagues. Several nurses have reported being emotionally checked out from their work, ultimately affecting patient care. So we've talked about the role and the value, and we've talked about definition of burnout and prevalence. So let's pivot now to discuss some of the identified causes of physician burnout. And we can start by reflecting on the traditional physician work culture as we know it. By so doing, we can examine if this work culture has any direct or indirect correlation with a predilection for burnout. And we should well understand that physician work culture is shaped through the lens and experiences of medical students and physician trainees during medical education and residency training. Several of you here have lived and are living this experience. So you know that as soon as a pre-med student gets on the conveyor belt that is lurching towards a career in medicine, he or she is exposed to and indeed is expected to and embraces competitive individualism, embraces the evaluation of basic humanistic qualities, and is expected to accept verbal and emotional harassment and indeed intimidation from their mentors and teachers. We are taught as physicians in training to embrace work-life imbalance as a badge of honor. I'll say that again. We are taught as physicians in training, begin to see this as medical students, to embrace work-life imbalance as a badge of honor. It was with pride when I was a medical intern and resident to say that I had been on call and I didn't sleep all night. And here I was the next day at the grind and seemingly doing well. Hopefully that sentiment is changing, and needless to say, enrollment in medical school is dropping for several reasons, one of which is the work-life issues. The new generation of millennial physicians are seeking more work-life balance. And in certain circles, they are being bold enough to challenge the status quo. There are several industry challenges and headwinds and mega trends that are depicted on this slide that have all adversely impacted the workload and work-life balance of the physician and have caused or contributed physician burnout. From the constellation of chronic disease burden in an increasingly aging population that taxes primary care physicians' effective and efficient management of individuals, to the rising demands of consumerism, where there is the need for immediacy in responses and face-to-face interactions and the demand from the consumer, to the demands by regulatory bodies for appropriate value-based care, whereby the industry in general must be held accountable for outcomes, but outcomes at the best price. Physicians are being pressurized to see more patients in a declining reimbursement and compensation environment, and to be able to demonstrate quality in the absence of infrastructures that can actually track performance. And that brings to the fourth bullet here, business intelligence, where there's a daily need for physician interaction with the necessary but inefficient business intelligence tools, such as electronic medical records. This is needed, of course, to care for patients. When I began my practice, we used paper. In my practice in North Carolina in the early 1990s, my cardiology practice was the first to embrace electronic medical records before it became sexy in 1990. It took us about maybe 12 weeks to decide that spending $1 million on an EMR was potentially worth the risk, as opposed to sending 6 of our doctors up to Boston from North Carolina to do some beta testing and to develop an EMR. Well, my point is that there was a time we used paper. And those of you that, some of you are in the audience here that actually used paper before EMR, realize that EMRs are a necessary evolution. But EMR 1.0 and 2.0 is not the solution. The design of EMRs, we all know, are compliance machines that favor reimbursement. And physicians have taken a quantified toll in having to use these EMRs and to be held accountable for them. So still on the topic of causes of physician burnout. Now, according to research done at the Mayo Clinic, what you see on this slide are the 6 main drivers of physician burnout: excessive workload, loss of meaning in work, organizational objectives that conflict with the altruistic nature of the profession, problems with work-life integration, loss of flexibility and control over work, inefficiency and undue clinical burden. Now we need to examine these drivers further and to dig deeper below the surface to understand if these drivers are actually mere organizational symptoms of an underlying and more deeply rooted organizational dysfunction. And as physicians, we do understand that symptoms may be on the surface of something much more fundamental. So where am I going with this? So those of you that have read about or studied physician burnout will be familiar with Dr. Christina Maslach. She's a social psychologist, a professor of psychology, and a pioneering authority on professional burnout. One of the many books that she has written on this topic, The Truth About Burnout, asks the provocative question: is there fundamentally an organizational culture component that is the dominant cause of professional burnout? The book goes further to actually answer that specific question, and it does so by debunking the myth that the individual is solely responsible for burnout due to personal failings or insecurities, but rather the book shows that accountability for physician burnout falls squarely on the shoulders of the organization within which the burnout is manifesting. The book challenges organizations to stop blaming individuals and to start to treat physician burnout as a system issue. Now, Dr. Maslach goes beyond that to lay a roadmap as to how to deal with this. But before I get to that, let's talk about the consequences of burnout, the impact of physician burnout, economic, personal, societal. So burnout is costing the US healthcare system almost $5 billion a year as a result of reduced hours for a variety of reasons, physician turnover, and expenses associated with finding and hiring replacements. Physician burnout results in poor job performance and a lack of alignment of the physician to the organization. Physician burnout creates the nidus for medical errors and malpractice and suboptimal patient outcomes. Physicians are seeking non-clinical second careers due to work-life dissatisfaction. 40% of doctors surveyed by the Physician Foundation indicate that they plan to drop out of patient care in the next 1 to 3 years. Burned out physicians are more prone to seek career changes in their late 30s to 40s, way before the peaks of their career, and switch to big pharma, to health insurance, managed care, health administration, health resource utilization, etc. And some physicians seek a second degree like an MBA and focus on finance, venture capital, management consulting, etc. Now the last one sounds like me. An MD, MBA in management consulting. And if you don't know what Ernst & Young is, EY, Ernst & Young, is one of the big 4 accounting companies. But as all the big 4 accounting companies do, at large healthcare management consulting. And my role as Chief Medical Officer is to engage clients across the country, healthcare systems, about a variety of things. I practiced interventional cardiology, I will say, even if I say so myself, at a very high level, up until 2016. I was actually a structural heart cardiologist. And I was a medical director of structural heart in a $5 billion healthcare system headquartered in North Carolina, 14 hospitals. I used to run the Heart and Vascular Institute. In January 2012, I led the team that did the first transcatheter aortic valve replacement in North Carolina and South Carolina. Now, along my journey, I did an MBA, and I did an MBA not because of burnout, because I actually was not burnt out. I was fairly very satisfied with my career. But I did an MBA because I was involved in hospital administration and leadership, and did it to become a better leader. But the truth of the matter is that having done the MBA, after my first of 2 years doing a working professionals MBA, the light bulbs began to go off rapid fire about the gross inefficiencies, the lack of value, the failure for the industry to objectify value to the patient, the lack of appreciation that the most important stakeholder in the value chain is the patient, the lack of data transparency, we have costs and outcomes. Those things began to bother me and interest me. It took me 2 years to realize that I wanted to stop practicing clinical medicine, to step out, to get engaged in high-level thought leadership conversations like this, where I could engage healthcare system CEOs, CMOs, to first understand the value of the physician enterprise. Because the reality is, if you have a disengaged physician enterprise, strategic imperatives and transformation initiatives, reform initiatives are unlikely to succeed. So I took a leap of faith and left my comfort zone with a very strong brand to go to reinvent myself to a new career where I had no brand. So I have an MD and I have an MBA. I did my MBA late in my career, about 10 years ago. And the other issue is that there are not enough of us doctors that understand the business of medicine. We don't all have to do MBAs or MHAs. But I think fundamentally we have to take a responsibility to understand the business of medicine. And we need to develop physician leaders that understand that medical directorships are not popularity contests, they are obligations, and there's responsibility to hold our peers accountable. So, I would encourage younger physicians to consider MPHs, MHAs, MBAs. You don't have to leave medicine, but there is the need for more physicians that understand the business. So I said in my opening comments that I consider physician burnout to be a public health crisis. And I say that with, and you should understand this realization, that more than 50% of the combined physician and nurse workforce are already manifesting few to several symptoms of professional burnout. So what does that mean? That means that the very professionals at the bedside, touching, soothing, comforting, and dispensing care for patients, this very workforce at the bedside is fundamentally manifesting some form of hidden dysfunction that must invariably, inevitably have some impact on the quality and safety of care delivery. It should be no surprise, I alluded to this earlier, that medical errors are prevalent and are the third leading cause of death in the US today. And absent of an industry-wide strategy and absent of a concerted effort to mitigate this public health crisis leads me to conclude that it being ignored is in of itself nothing short of an embarrassing paradox and a fundamental failure. As an aside, another effect of physician burnout is that despite the enormity of this public health crisis, we now see that physician burnout has become, in some forms and within certain forums, a buzzword of the times. Similar to the buzzword of healthcare disparities 10 to 15 years ago, similar to what happened then is happening now in the sense that physician burnout has spawned a whole cottage industry of experts and speakers working the lecture circuit without any significant impact on the problem itself. So, let's move to diagnosis. How does the physician who is burnt out get diagnosed? Now this can be, as you well imagine, extremely difficult, especially if the physician is loath to seek medical attention, especially if the physician is particularly loath to be labeled as having some form of mental health challenge, and especially when physicians are apt to be people who embrace the notion that verbalizing symptoms of burnout or seeking help is a sign of weakness or professional failure. You know, as doctors, we understand that symptoms that are described on this slide, cynical or negative attitudes towards patients, exhaustion, depression, lack of empathy, depersonalization in clinical interactions, are usually the external manifestation of an internal dysfunction that may not be internal to the physician himself or herself. In the same vein, the symptoms of burnout should alert us not just to the need for symptomatic intervention, which is important, but also to the need for the identification of the deep-seated lesion that lies within. I mentioned Professor Christina Maslach earlier and her book, The Truth About Burnout. Now that is one of many books she's written. And in her life professional story, she has done more than just identify the causes of burnout. She's actually chronicled processes to remediate the problem. The Maslach Burnout Toolkit is a combination of two competencies put together to diagnose workplace burnout in general and physician burnout in particular. Through these two competencies, Dr. Maslach and her colleagues have developed time-tested competencies that diagnose, monitor, and demonstrate evidence of individual burnout. In addition to that, they identify organizational causes of and organizational contribution to burnout. What you see on the slide, the Maslach Burnout Toolkit combines, on the left, the Maslach Burnout Inventory, which is recognized in the industry as a leading measure of burnout, been validated by extensive research that has been conducted in more than 35 years since its initial publication. In combination on the right side with the Areas of Work-Life Survey authored by Professor Michael Leiter and Professor Maslach, the AWS assesses employees' perceptions of work qualities that play a role in whether they experience work engagement or burnout. It's a companion to the burnout inventory. And it produces profiles of scores that permit users to identify areas of strength or weaknesses within their organizations. The MBI, the Burnout Inventory, assesses emotional exhaustion objectively, assesses depersonalization, feeling and impersonal responses toward patients. It objectively assesses personal accomplishment, feelings of competence, and successful achievement in one's work with patients. This work has been validated through research and has been present and available for more than 35 years. Concurrently with the MBI, The AWS survey measures workload, control within the work environment, a sense of reward, sense of community, sense of fairness, and a sense of value. So both are providing visibility into the organizational cause of burnout and the workforce implications thereof within healthcare professionals in an organization. Importantly, this approach emphasizes the importance of organizational awareness, ownership, commitment to remediate, and investment to do so. It is well known that the behavior of physician supervisors, clinical or administrative, have a large impact on physician burnout. So this teaches participatory management characterized by leaders who engage, inform, empower, develop, recognize achievements of their physicians, by so doing reduce burnout at a very granular level. Physicians and leaders working together constructively identify, develop, and implement solutions for problems in their environment. And this demonstrates real-time to physicians that improvement and self-empowerment is both possible and it works. You've all heard about the DAD models of care. Those are good places to start, for as long as they're functional and transparent in knowledge sharing. So a word about the importance of physician resiliency programs. Several organizations are now investing in the business of physician resiliency program development in the context of channeling patients in a reactive manner who have symptoms of burnout to go for treatment. Now, if these programs are stood up with the pretext that the problem is the individual, they are bound to fail. But these programs are crucially important in that they are designed to positively impact both the physician and administrator in engagement and alignment. And they have to demonstrate an organizational investment by the health system in a process to not just have a reactive remediation, but to have a sustained, ongoing process of prevention, identification, and treatment. So key organizational aspects of physician resiliency programs of note are that we need to start trusting physicians again and not considering as healthcare leaders that physicians are mere widgets that need to just go and work. We need to understand the impact of intrusive regulations that don't add value to patients' medical care. But we need to be willing to devise more accurate approaches to assessing quality. We're clinicians. Fundamentally, we're scientists. And I say often that healthcare providers, hospital systems, and doctors have abdicated our fundamental responsibility to oversee and adjudicate on quality. And we have therefore allowed others to step in and define quality for us. The quality metrics that are being measured across clinical service lines, we all know, don't really represent quality. They represent compliance. But why is this? We, the physicians, we, the scientists, we, the owners of evidence-based medicine guidelines, have stepped aside and let payers now tell us what quality is. So, organizations need to now be willing to set workload expectations based on what it takes to provide good patient care. Physicians also have to understand that they need to generate revenue to cover expenses. Fundamentally, data analytical tools, digital platforms, and integrated connectivity for business intelligence that can measure, track, and benchmark performance, as well as the well-being of physicians, should be a strategic imperative to provide high-quality care. And as I said, a word of caution about these programs, these resiliency programs. We must not just treat the symptoms, we need to dig deep and see if there's an organizational problem that feeds the problem. We must understand that an individual organization that is committed to this at the highest level of leadership, and one that invests in well-designed interventions, can move the needle and run counter to the national trend of physician distress and burnout. Now, thought leadership around medical school training and professional training of physicians is beginning to reimagine the future physician workforce and the role of medical school curricula and medical training. Interesting to note that Western medical school curriculums in general have not changed significantly in the past 150 years. It is now proposed that there should be a shift from teaching to learning. It sounds simple, but it's there's a very fundamental difference. And this impacts processes that start from admission requirements, accreditation of institutions, the need to exploit and unleash the power of IT-enabled learning, and fundamentally to break down the silos between professions within healthcare, between physicians, between public health professionals, between nurses, social workers, and the community, and nurture a team-based collaborative culture of critical inquiry. So as I soon draw to a close here, I want to shed light on a few case studies on organizational commitment to address physician burnout through alignment, on the one hand, to shed light on physician resiliency programs, case study, on the second hand, and thirdly, to shed light on medical schools that are redesigning their curriculum to be more relevant for the workforce of the future. These are all designed directly or indirectly to create a more stable and fulfilled and engaged physician enterprise in the near and distant future that will directly or indirectly reduce the impact of physician burnout. So at Mayo Clinic, the Listen, Act, Develop model focuses on physician engagement as a strategy to reduce burnout and involves physicians in the mission of the organization. The Listen, Act, Develop model for listening actively seeks to identify and understand burnout drivers that I described. To act, it empowers physicians to develop and implement solutions to address the top burnout drivers within their particular workspace or experience. Cultivates physician leaders in the context of the empowerment work and commits to a continuous cycle of process improvement. It emphasizes there are three factors physicians need to thrive with. Choice. Physicians want a degree of control over their lives, which includes the flexibility and input over process change. Control within reason. If you have a primary care practice and the most senior physician sees patients for 1 hour at a time and everybody else can be efficient and see physicians for 20 minutes at a time, the flexibility has got to be objective, and variations, human variation and process variation has to be explained to be adopted. Camaraderie and social connectivity, socializing with team members and colleagues, has been demonstrated to improve spirits, collaboration, and reduce burnout in a meaningful way. Excellence. Physicians want to be on a winning team and part of a meaningful organization. Leaders who establish relationships with physicians encourage them to achieve excellence in their practice. So what has evolved from this Listen, Act, Develop initiative at the Mayo Clinic? So it has demonstrated a 17% increase in workplace morale, a 12% improvement in workplace teamwork, 11% improvement in satisfaction with information and handoffs in the workplace, and a 50% increase in the targeted units in satisfaction and engagement, or both. At Novant Health in North Carolina, a case study on leadership development, which has specifically targeted physician participation as a means to identify and alleviate burnout. Of the more than 800 physicians that have participated, physician engagement scores have increased 40 percentile points by Press Ganey data. And it looks at 9 critical elements, learning how to operate from a deeper personal understanding of a physician's purpose. Develop a keen sense of personal awareness and understanding of how non-conscious patterns of bias, behaviors, and thinking contribute to burnout, and so on and so forth. Now, new models of medical school curricula are emerging to train and provide a workforce that is more relevant to the evolving skill set that is needed to function optimally and efficiently from a clinical performance perspective, as well as from an emotional and a physical perspective. So at Dell Medical School in Texas, its curriculum is centered on healthcare value, leadership, interprofessional collaboration that diminishes the unilateral decision-making burden on the individual physician. And it does so by developing in medical school a culture of coordinated interdisciplinary teams to provide approaches to care that include the physician, the nurse, the pharmacist, social worker, and others. Now, these teams exist already, but this new model is a participatory leadership and decision-making framework where, while the physician is the captain of the team, teams are encouraged, all team members are encouraged to practice with a questioning attitude. So if during a code, the anesthesiologist or cardiologist or the emergency physician says, give 10 milligrams of epinephrine, the nurse has got to be confident and rooted in his or her understanding that that is an unusual dose and it is a toxic dose, and should be empowered to say, Dr. Aluko, did you mean 10 or did you mean 1? That is questioning, is practicing with a questioning attitude. And you all know that in multiple pockets in healthcare circles, doctors give orders that are wrong, and sometimes we know they're wrong and they're not questioned. Now, Kaiser Permanente's final case study, medical school, is expected to open in August 2020. And this curriculum is built on 3 pillars. Biomedical science, providing a basic framework of biomedical knowledge. Clinical science, emphasizing prevention, treating health conditions proactively. Health system science, the science of how human relationships organized in systems influence health. Social determinants of health. 4 threads run through the curriculum: equity, inclusion, and diversity, health promotion, and again, interprofessional capabilities and leadership. So this concludes my thoughts this afternoon on the topic of physician burnout. I hope that I've provided you with some insight into the scope and severity of the problem. But more importantly, I hope that I provided you with some direction that both you as individual doctors can take to mitigate this malady, as well as health system leaders. There are few professions in life, such as medicine or nursing, where you know that when you wake up in the morning, you get out of bed, and you put on your clothes, you get in your car, you go to the hospital or the clinic, invariably, you are going to help somebody live longer and feel better every single day. This is no random act of kindness. Everybody does random acts of kindness. This is a vocation, but the value cannot be overstated. Every single day, time and time again, the doctor gets up, the nurse gets up to go and help people. So with that being said, I hope that at your healthcare systems and you, when you go to your private corners, will begin to develop processes for physician enterprise workforce nurturing and develop steps that you can take to develop personal and organizational competencies that allow your hardworking physicians and nurses to be physically and mentally restored in order for them to be as productive to society as they can and as they desire to be. And most importantly still yet, for them to see themselves to be valued professionals within the healthcare industry. And with that, I thank you kindly for your attention. Yes, sir.
Very nice presentation. Question. So what has, thank you. What has insurance agencies, Medicare, has done to recognize and help health systems solve this problem of physician burnout?
I'm not aware of any systemic processes that are coming from insurance companies. Like I mentioned earlier, there's a lot of conversation about it. This is not a new phenomenon. These observations have been in existence for decades. The interesting answer to your question is that the solutions are already evident. They are present in the Maslow burnout inventory. Who is responsible for taking on this morass? I would wager that it is primarily the healthcare system providers that begin to embrace this responsibility and partner with healthcare payers. I don't believe that we should expect the payers to own this.
Just as an example, we are going through some changes in many institutions. So they are paid less for each physician visit. The hospital is getting paid less, so they have no resources to be able to provide the listed things that you have there. Rather, it's opposite, and they are demanding to perform more in the less that they have or are being given by these people.
This is true. This is a complex situation. Physicians, especially primary care physicians, are told that they lose money, paid less for each interaction. I spoke about physician value. Physicians themselves, the physician enterprise, and indeed healthcare systems are challenged without having the ability to actually demonstrate the monetary value of a primary care doctor. If you look at a primary care doctor working in his or her bricks and mortar of an office, you look at the P&L, and there's an investment or negative cash flow. Administrators are apt to say that they're losing money, and the doctors are apt to say, well, we're being paid less, and we're seeing more people. But one missing piece here is not understanding the net revenue that the primary care doctor, or indeed any physician, is delivering to the healthcare system. A well-managed primary care practice, well-managed, may lose, so to speak, $50,000 per doctor, well managed, but should generate, if well managed, about $1.2 million to the health system per doctor, net revenue. Now, that's value. If the industry is indeed reducing reimbursement. We don't have control over that. But what we do have control, should have control over, is to be able to codify the value that the physician is delivering to the healthcare system, so it paints the picture in a different light. And it also empowers the physician with the knowledge that I am actually delivering value to my organization. The office in which you operate is just one piece of it. The primary care doctor sends a patient to me. The primary care doctor sees a patient for chest pain. He may charge $100 for the visit. And maybe do an EKG. May get reimbursed $5 for that EKG. Sends it to me, patient to me. And I, as a cardiologist, will do a consultation, an echocardiogram if needed, and a stress test if needed, maybe $5,000 in my office. Send to the hospital, do a catheterization and an intervention. The patient leaves the hospital with a bill of $50,000. Or the person needs open heart surgery, $150,000. Now this began with one primary care doctor that is given credit for $100. But it is that acumen of that primary care physician that identified the need for referral to a specialist. That person identified the need for appropriate patient care within a health system that generated significant revenues for the system, as well as took care of the patient. So that just demonstrates the inequities within this money flow chain.
Yeah, can I ask a question?
Please.
Just as a follow-up, I don't think that getting more money to the doctors is going to solve the problem of burnout. From what I understand, that burnout problem begins probably in medical school, where the lifestyle is kind of given to us that we must do super efforts to become physicians, and then when we get into practice, the workload and lifestyle kind of gets us down. But one solution could be to think about what's going on in Europe, a managed care where if you could explain to me if the doctors over there, which get less paid and maybe a better lifestyle, have less burnout.
Well, I hope I didn't suggest that more money solves the problem. I don't think I said that at all. But I did state that the value of physician work is not uniformly appreciated and is not even understood by the providers themselves as to what their monetary value to the system is. So I wanted to clarify that. Now, the United States has the highest expenditure on healthcare in the world. It has physicians in the United States are the highest paid in the world. Medical education in the United States is the highest probably in the world. So when you talk about adopting pay structures that exist in other countries, one has to understand that several of these countries sent people to medical school for free or highly subsidized. And there is a culture within the United States that didn't begin recently. It is decades in the making of physicians, especially specialists, commanding very high salaries. Your question really speaks to when are we going to talk seriously and when are we going to be able to actually reform the healthcare delivery system in the United States and create healthcare access, create work lifestyle parity that doesn't destroy providers. More importantly, create methodology to track performance that enables you to be paid for performance. So you're talking about healthcare reform as well as a transition to value-based healthcare. And you well know, you live closer to Washington, D.C. than I do, that these are very contentious and very, very undetermined, volatile topics.
Just simply, is the burnout ratio in doctors in Europe, which have more or less socialized medicine, isn't the burnout rate much less?
It is much less.
The salaries are probably much less, but the lifestyle and their participatory influence in the system is greater. So if we kind of move toward that system, wouldn't we begin to solve the burnout problem in the United States?
Yeah, I think that that is a simplistic way to look at it, but yes, there are some countries where physicians learn very handsomely abroad. But you're talking about health policy, you're talking about health reform. And one of the outcomes for health reform and a rejuvenated health policy should impact work-life balance amongst all stakeholders within healthcare.
Thank you.
Thank you very much. Thank you very much for this complex presentation. For somebody who's been in practice for almost 50 years, it's gratifying that at this particular time I'm hearing about this for the very first time. It is also gratifying that other organizations such as the medical school in Texas you mentioned, Kaiser and so on are beginning to tackle this problem. The question I have is, in our large organizations like the American Medical Association, the American Academy of Pediatrics, which is attended by large numbers of physicians, is this problem being addressed there at all?
It is actually being addressed. But then again, as you well know, the AMA does not have that jurisdiction over individual hospitals or practices. The AMA can espouse policy recommendations, but to develop internal health system transformation is the responsibility of individual health system leadership. This conversation is not a new one. And yes, the AMA, our professional organizations are definitely talking about this. And this is what I mentioned earlier, that there's a whole cottage industry of conversation and literary discourse and intellectual discourse about it. But putting process to corrective actions is what is lacking, despite the fact that the evidence base exists as to how to do it. Thank you. Thank you very much.